this is fine, I think. Let me have this. Oops. So I was asked to present the best of the best in GI. So I was in Washington, and I tried in preparation for this presentation to be as general as I can be and look around what is available. Obviously, things that I saw on the agenda that would be presented by other speakers and other colleagues, I try to avoid, so hopefully we'll have a minimal overlap with the other presentations. So Washington is getting interesting. I was there a few years ago, before the Trump era. The buildings are a little different, and what you see outside the buildings also is different. So it's an interesting place to visit every 4 or 5 years as the people at the White House change. Today also is Bastille Day, for those of you who are the Francophiles. As you know, Bastille is the French Revolution, about change, about difference, about excitement, anticipation. It's celebrated today. Tomorrow, the French are going to play the Croatians for the World Cup, so it's going to be an interesting thing to see. But apropos to this revolution, I thought that I should present something that has to do with revolution in GI. So I'm going to try to give you a little potpourri, if you will, of things that I think made an impact for me to see and to watch and maybe change or revolutionize our practice. So you will have a little bit of a flavor of clinical as well as some research information. So the first one has to do with a common theme, which is the resumption of anticoagulants after hospitalization for GI bleeding. And this was a meta-analysis of the evidence that we have so far. I think all of us practicing gastroenterology are faced with this question, should we or should we not put patients back on anticoagulants after they came in for the GI bleeding? So this was a systematic review and meta-analysis of different studies to determine basically the risk of recurrent bleeding, but also thromboembolism, which is obviously the other side, and mortality after resumption of anticoagulation after GI bleeding. So they analyzed the randomized controlled trials as well as cohort studies in those patients who had atrial fibrillation, venous thromboembolism, valvular heart disease, etc. And they had data on the management of anticoagulants, and they looked at outcomes, basically 3 outcomes: the recurrence of GI bleeding, the recurrence of thromboembolism or some kind of a neurologic event, and mortality. And they actually looked at those who had resumed anticoagulation or stopped anticoagulation after a gastrointestinal bleeding. And this is the results in a summarized fashion. The risk of thrombosis is less, significantly less. The risk of death is, as you see there, significant. And the risk of bleeding goes up. So it's a very significant imbalance. So you have a risk of bleeding that is enhanced, a risk of thrombosis that is decreased. And so basically the message is that you have an increased risk of recurrence of GI bleeding, but also have a significant decrease of thromboembolic events and all-cause mortality. So it's, I think to me, this is a validation of what we should be doing. Obviously, we're going to be kept busy by resuming the anticoagulants. They may come back with bleeding, but that's not as significant as the risk of other much more dramatic events. Another interesting kind of report on endoscopic information, an exciting combination of tunnel endoscopy and nodes procedure, is this concept of so-called POEM plus F, which stands for peroral endoscopic myotomy for achalasia, followed by a fundoplication, all done through the endoscope. I think to me this is not only a proof of concept thing, but it's an intriguing scenario that you may eventually get to a point that you may even treat reflux with endoscopic fundoplication that is done using tunnel endoscopy and nodes procedure. And I will show you how this is done. You do the POEM, and you do a submucosal endoscopy, and the endoscope is then advanced into the peritoneal cavity. You create a pneumoperitoneum with CO2 insufflation through the endoscope, and then you grab the anterior wall of the gastric fundus and you anchor it with 4 endoclips and an endoloop. And then the endoloop is fixed again to the distal end of the myotomy with additional 3 endoclips. And then you close the tunnel and you go home. So it is something that is very intriguing to me. I don't know any of us in the room is doing POEM, but this is the new wave, if you will, in advanced endoscopy. And this is, by the way, from the same person who actually first introduced POEM, Hiro Inoue, from Japan. The data obviously is limited, but nevertheless, they did it in 12 cases. They created, or at least that's what they claim, a visually recognizable fundoplication at the gastric cardia. It took them 36 minutes to do. And the clinical course after POEM plus fundoplication was uneventful. The hospital stay and the dosage of pain controls were about equal to the classic POEM. And they did 24-hour pH impedance monitoring 2 months after the procedure in 4 patients, and they did not see any reflux. Remember, this is achalasia patient population that you create the myotomy to treat the achalasia, and because the risk of reflux after POEM is in the range of 50 to 70%, you may decide to do this in conjunction with a POEM to do the fundoplication endoscopically with minimal amount of extra effort, if you will, according to them, and you can hopefully prevent long-term reflux after POEM. So this combined technique of tunnel endoscopy and nodes promises to reduce the likelihood of GERD post-POEM, and in my mind carries the potential promise for endoscopic treatment of GERD in the absence of achalasia or significant hiatal hernia. The next topic that I thought it would be very clinically important is the management of idiopathic bleeding ulcers. And all of us are familiar with the main reasons for ulcer formation, which is Helicobacter and aspirin or nonsteroidal use or antiplatelet use. But we're not talking about this situation. We're talking about the patient population who has ulcers that are not aspirin-related or NSAID-related or Plavix-related, and they're not Helicobacter pylori positive. And what do we do with those patients? They are at considerable risk for recurrent ulcer complications even after years of the index bleeding event. They hypothesize that a PPI, in this case lansoprazole, is superior to an H2 blocker, in this case famotidine, for prevention of recurrent ulcer bleeding. So it's a double-blind randomized trial in Hong Kong. They took these patients with a history of idiopathic bleeding ulcer. They randomized them 1-to-1 to lansoprazole 30 or famotidine 40. The primary endpoint was recurrent upper GI bleeding. Secondary endpoints was any kind of GI bleeding. They did an intention to treat analysis. And this time at DDW, they reported a blinded interim analysis of findings at 12 months. And what you see here comparing the PPI to an H2 blocker in terms of bleeding and in terms of ulcer recurrence, you can still see here that even on it, of course, the PPI is better than the H2 blocker in terms of the bleeding diathesis, but you still have a significant percent of patients bleeding despite the fact that they're maintained on a PPI. So to me, this is a very interesting and challenging group of patients that we need to really be continuously vigilant about. There's something about this patient population that despite all of the other underlying factors that we have taken care of, and despite ongoing acid suppression, they still come back with significant GI bleeding. So the message is that this is a significant clinical issue with a risk that goes up to 6%. There are strategies that are equivalent numerically. Of course, PPI was better, but we're going to have additional data coming up next year. And the risk of ulcer recurrence is up to about 2%. So this is something that we should not discard as a clinical issue in our practices. Despite the fact we have cleared up H. pylori, we have stopped the aspirin and non-steroidals, there are some people who will actually have ulcer recurrences. I want to switch gears a little bit from the clinical stuff that I just presented to talk a little bit about innovation and present things that are kind of in the very, very early stage to kind of tease you. It's a Saturday morning. It's a good time to do that. So let's say imagine making the diagnosis of IBS by taking a cardiogram of the abdomen and relating abnormal gut motility patterns with specific symptoms, or differentiating intestinal obstruction from inflammation in, let's say, Crohn's disease, diagnosing IBD, or monitoring the progression of diseases of the gut, understanding the impact of diet or drugs or on gut function, and probably even to decide how to expedite gut recovery and feed patients early after surgery. So if we could have a tool of this nature, I think it would be actually, and if that tool is validated, I think that would make a significant difference in our daily life, particularly those of us who see patients with irritable bowel syndrome, dyspepsia, etc. So this is basically a concept that comes up of how we can record what's happening in the nervous system of the gut. And I don't want to bore you with the details of the neuromuscular apparatus of the intestine, but basically you have excitation potentials that you see here, and how can we monitor these things, and to what degree the acquisition of this information from the gut as it moves can be useful clinically. So for example, in the stomach, we have a classic pattern that you see here, followed by a small intestinal pattern. This is a motility test that we do in the clinic, but it takes 6 hours or so, and the catheter down the patient's throat, and recording, and the patient is stationary, et cetera, et cetera. So the concept of an EKG of the gut that would measure electrical signals from the different digestive organs has been somehow a very long dream for many of us, and it's becoming now closer to reality, of course, with appropriate validation. It will be mostly useful, in my mind, for the understanding of functional gastrointestinal disorders, and hopefully help us target therapies and management of these disorders. In particular, it could be a non-invasive, inexpensive alternative to different anatomic tests, or after anatomic tests have been done and excluded a structural process, one could actually go on to this approach. So this is the GTECH patch. This is a patch that goes on the anterior abdominal wall, and it's worn for, at this point, up to 3 days. So you wear this and you go home, and this thing is recording my electrical activity of the gut, and it sends it through the cloud, through an app, through the cloud, to, let's say, a central repository. They have the data acquisition, processing, filtering, and a variety of other things that they do with a computer. And then they give you basically a report, in principle, that tells you how the stomach, the small bowel, and the colon was behaving during the period of the recording. And basically what you do is you look at the different frequencies. The stomach has a frequency of about 3 CPMs. The small bowel goes from 5 to 12, and the colon goes from about 12 to 25. And you see, you generate plots like this, and these plots are in the normal domain or the abnormal domain, and then you start doing correlations with symptoms, correlations with disease, and so forth and so on. And they showed some data on the reproducibility of a particular recording over time. So these are healthy volunteers, 3-day recordings, and you can see that the different colors of the lines are superimposable on each other on the 3 consecutive days. And then they presented also some data on an entity that the surgeons mostly deal with, which is the postoperative ileus state. And basically they looked at the prediction capability of this recording to allow the surgeons to say, oh, the gut function has recovered post the Whipple procedure and the patient can be fed on day 2, as opposed to let's wait for the passage of flatus or whatever, and then let's say start the patient on feedings at day 5, and therefore save 3 or 4 days of hospitalization because we have fed the patient and moved the patient forward to the discharge planning. And they also did some interesting correlations between the recordings obtained and acquired from the patch on the skin to something that's called a smart pill, which is a capsule that goes through the gut and generates data on pressure, pH, and temperature. And when the capsule was in the colon, they were able to get colonic signals on the patch and vice versa. So there are all kinds of validation experiments that they presented, and that was actually, I thought, quite interesting. So the message is that technological advances have made prolonged myoelectrical recordings feasible under both physiologic as well as pathologic conditions. This is a cloud-based collection and analysis that allows immediate input and eventually therapy. Of course, it will require validation, both in health and disease, to define gut signatures, if you will, so anybody can read these things. And then, of course, symptom correlations in response to drugs and diet could be made. And, of course, the holy grail of gastroenterology, to validate the presence of IBS. Imagine to tell the patient, you have IBS, and it's not because Dr. Smith tells you so, it's because this machine tells you so. That, to me, that would be life-saving. So back to Washington, some additional sightseeing. I passed by Mr. Mueller's office and Mr. Giuliani's office, and it was an interesting architectural experience to see all these buildings, and also other buildings where our government decides about what to do with research money and what is the appropriation of the research funds. So another study that I also decided to share with you, this is my study, but I thought that I should share with you. We presented at DDW and it's in press already, is the PPI use and its potential for long-term effects. Can we avoid them? And I think, at least in my practice, I see that daily. Patients come in, they say, Doc, I don't want to be on a PPI anymore for my reflux, for my Barrett's, for my whatever. And so I think that the classic approach is to treat patients empirically with PPIs may be, I think, not a good idea anymore. So what we did is we used ambulatory esophageal pH monitoring to minimize PPI utilization in patients with GERD symptoms. This was a retrospective cohort analysis of about 280 patients that were seen prospectively with this approach. The approach being you do an endoscopy, a motility, and a pH monitoring, basically assessing the patient at the time of presentation. So what you see here, out of these patients who presented with reflux symptoms, most of them willing to be off PPIs or wishing to be off the PPIs, that they were placed on PPIs from either the primary gastroenterologist or typically the primary care. You end up seeing, as you can tell here, about 36% of these patients do not have reflux when you study them. So they have been treated with PPIs, and the diagnosis was wrong. And the other percentage, which is obviously significant, 64%, had an abnormal pH. And then you look here at the different scenarios about who were never on PPI, who stopped the PPIs, and who continued the PPIs. So this is basically the message. that you can actually avoid the use of PPIs in many of these patients. But let me show you the data, how at least I manage these patients. If the pH is abnormal, I then look at the acid exposure time, and this is arbitrary, but this is how at least we generated this information, and that's how I've been practicing for about 5 years. So if the acid exposure time is less than 10, I consider these other strategies, specifically switching to H2 receptor blockers and endoscopic therapies. When the acid exposure time is very significant, above 10%, then we either go to PPIs or to surgery. And this is a little bit more detailed presentation of what these people had. These are different diagnoses that you see on the side who had normal or abnormal acid exposure time. And the different treatments, and you can see here some patients, for example, one patient specifically had achalasia. So still we see patients who have been told you have reflux, they're treated for it, and they end up having achalasia, which is, to me, that's not a good practice. So the message is that this retrospective cohort study looks at the potential of using mostly ambulatory pH monitoring, but in conjunction with endoscopy and manometry to try to minimize PPI utilization. And you could theoretically, if the data holds true for your practice, avoid initiating or discontinue previously introduced PPI therapy in about 50% of patients, therefore minimizing the theoretical concerns about long-term side effects. Another study that I thought it was very important to share with you, because I'm sure it will change your practices, is the VA Cooperative Study, which is a randomized controlled trial of medical versus surgical treatments for patients with heartburn that is refractory to PPI. So are you going to do the knife or the pills? And this was a VA cooperative study that basically had a lot of difficult time to basically select patients to enter the study. These are patients who have a positive symptom association probability for acid or non-acid reflux, and they have abnormal acid reflux, and they were randomized either to laparoscopic Nissen fundoplication, that's straightforward, or medical therapy, which involved omeprazole 20 milligrams BID plus baclofen titrated up to 20 milligrams TID, followed, for those who failed baclofen, and a lot of them do because of central nervous system effects, by desipramine titrated up to 100 milligrams QHS. Or placebo, which is the omeprazole plus the baclofen plus the desipramine as needed to basically compensate for the medical arm. So it's basically a significant study that involves PPI non-responders or refractory to PPI therapy who have validation of the diagnosis, and they're either randomized to laparoscopic Nissen or to medical therapy. And the primary outcome was treatment success at 12 months, defined as more than 50% improvement from the baseline GERD-related quality of life scores. So they enrolled 366 patients, and almost 80% of them were excluded when they studied them up front. It was a very difficult study to do. But nevertheless, we have data so far on 78 patients that had positive symptom-associated probability, abnormal acid reflux in only one, and both SAP and abnormal acid reflux in 25. And they were randomized to surgery, medical, and placebo groups. Serious adverse events occurred in 4 surgical, 4 active, and 3 placebo patients. And the data is shown here so far at 12 months. This is preliminary data. The study is not completed yet. But you see the superiority of surgery over medical therapy assisted by the other things that we talked about, which is the desipramine and the baclofen. So I think for patients who are refractory to PPIs, these additional steps may not be particularly useful. So the message again, for patients who are refractory to PPIs, laparoscopic Nissen is significantly better at 12 months than active medical therapy. The additional agents plus PPI did not differ significantly from placebo. And again, as you can see, the careful preoperative workup and selection is essential to really streamline these patients to the appropriate direction. And I would like to thank you very much for your attention this morning on behalf of my group at Stanford, and thank you very much again. And I'll be happy to answer any questions.
Thank you very much, George. That was an incredible overview and a lot of amazing data, especially about things like PPI, which I think all of us are getting questions from our patients. We have a couple mics in the audience. There's one over there and one over here. If you guys had some questions, just George is here. It's our chance to pick his brain.
If they are responsive, these are refractory to PPIs. So that's the idea. So when typically there was a lot of resistance in going in the direction of surgery. And, refractory to PPIs, you should not take them to surgery. The people who do best with surgery are people who respond to PPIs, all kinds of things that we've been hearing over the years. And we on the medical side of things would start saying, okay, we'll add this baclofen, we'll add the cypramine for decreasing the sensory perception and so forth. These strategies, according to this study, are not working. So if you have a patient who is not really responding to PPIs, the next step, according to this study, and I think that I agree with this conclusion from my own experience, go to the direction of surgery. That surgery is a laparoscopic Nissen in this study. More and more surgeons these days do the LINX procedure. There are endoscopic therapies that could be considered, but they were not studied in this particular context. This was a classic, traditional Nissen fundoplication. And the population is a VA population. Another important message is that making sure that the patients truly have reflux. So the validation of the diagnosis and making sure that indeed these people have acid reflux and they have significant, even if they have functional heartburn, they have significant disease.
What was your complication rate in your Nissen? How many people had dysphagia and secondary symptoms?
Well, the study, of course, is limited in the sense that we don't have the fine data that was presented in an abstract form. But they had about 4 out of the 25 that they call serious adverse events. To what degree these were dysphagia versus some kind of a postoperative complication, I do not know the detail. The study is still ongoing. We're going to see more data as the numbers go up. And hopefully we're going to have a bit more of a fine, detailed analysis of what happens in the Nissen fundoplication group. But typically, you expect to see the usual suspects such as bloating, dysphagia, and so forth and so on.
And the endoscopic way, where you have to enter the peritoneum, what was your instance of infection?
They didn't say anything about infection. Apparently, in those 12 patients, everything went fine, which is remarkable, right? Everything went fine. But this is what you get in these early preliminary trials. When you ask them, and I know Hiro very well, in the usual Japanese style, very limited response. It's great, it's fantastic, and that's what you get. And then when the technique is introduced to the rest of the world by the average endoscopist like myself, not that I will ever get into this, but the point is that it requires, first of all, very good familiarity with doing the poem, and then also to have the, I would call the guts, to poke a hole and get out into the peritoneum, insufflate CO2, work around that, and then come back and close that. But again, remember that what you're doing is you're bringing the stomach up against itself to the area that you have poked a hole to get into the peritoneum. So in Japan, for example, if you do a colonoscopy and you perforate, right, you develop pneumoperitoneum. They don't blink an eye. They just clip, 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 then take a needle, push it in the abdomen, the abdomen deflates, and that's it. They don't even admit the patient. Imagine what you would do or I would do. I would call my lawyer right away. I mean, I would panic, although I have had that happen and I basically clipped and all that. So we're now starting to feel a little bit more comfortable with pneumoperitoneum in the West. I mean, 2 nights ago I was called, the patient had pneumomediastinum. I said, oh my God, you know, thoracic surgery, this and that and that. The minute that we secured that there's okay and there's no significant leak, now we're sitting on them. 5-10 years ago, we would probably cut this chest open and figure out what's going on and all that. So it's things are changing. Yes? Good, thank you. Well, the concerns about PPIs have been kind of increasingly reported. I mean, everything can happen with a PPI, from dementia to kidney injury to osteoporosis. So there's a list of complications, starting from the brain all the way to the toes, that can go wrong with PPIs. And because of all these epidemiologic studies that suggest some enhanced risk of developing X and Y and Z issue, people have started backing away from using PPIs. If there is a significant indication, and I think that's the point of the study about underutilized, if you study these people and you justify the PPI therapy, I think then that's great. But if you can avoid starting the PPIs, which you started empirically in a lot of the cases, because you may have some heartburn or dyspepsia, let's take a PPI, and then these people end up having that PPI for years and years and years. So I think that as long as the indication is there, and the indication in my mind is number 1, reflux, validated, number 2, Barrett's, validated, number 3, the co-administration of NSAIDs or aspirin in an elderly person who is at risk for bleeding. So, and of course, the Zollinger-Ellison situation. These are the classic indications, and if you have these kinds of indications, you must use the PPI because you don't have any other option unless you use surgery for the reflux patient population. And the Barrett's population, even if you do ablation, you still need to use the PPIs in that cohort. So if there is an indication, you really have to accept that risk, theoretical risk, I should say, over the significant benefits.
Do you feel though the public's perception of PPI safety is inflated?
I think it is inflated personally. I think a lot of that data, actually all of the data is epidemiologic. It's hypothesis generating. It's not proof. It's not randomized controlled trials. The risks are not huge. I mean, we're talking about 1.7 odds ratio, 1.8, 1.6. We're not talking about 20, an odds ratio of 20. I mean, we're not talking about a very serious, I mean, a variety of variables can get in and complicate that equation. Yes?
Thank you, George. My question is more general. Like, how do you really define refractory PPI? Is it just based on the type of PPI that you see, or do you do?
That's an excellent question. The studies that are done to look at this refractory PPI, they actually are divided. Some of them is once a day, irrespective of the PPI, at the standard dose of the particular PPI. Or more studies actually expect you to have 2 PPI, I mean twice a day PPI at a particular dose. Let's say omeprazole is 20 BID. That would be a refractory PPI patient. So in terms of the other question, which is what do I do or what should we do? I think all of us, I think appropriately so, switch to another PPI. So let's say you are resisting or refractory or not fully responding to, let's say, omeprazole BID, you switch to either whatever dexlansoprazole or esomeprazole to whatever dose range you want. When we did this experiment some years ago at the VA, where, probably that still happens, the government changes the contract. So you go from omeprazole to whatever, lansoprazole. So all of a sudden, overnight, all the vets at the Palo Alto VA were switched from omeprazole, that they were doing great, to lansoprazole. And when I did this assessment for the entire, I guess, the Palo Alto VA population, which was a significant chunk of people with a pharmacy department, we found that just switching alone helps about 10% of patients. And also does not help the another 10%. So basically, it does not really make a big difference to the system, but theoretically, there are patients who respond to one PPI better than the other. So switching around is a useful exercise, I think.
George, I have one question about PPIs. Just in practice, if you do have a patient who has a good indication for long-term PPI use, especially things like Barrett's, do you, in your practice, monitor these patients with blood work or anything else like that?
Yeah, that's an excellent question. I don't think there are guidelines for that. I personally do what I will tell you in a second. I tell the primary care that this person needs to be on a PPI, and I ask them to check once a year with their blood for creatinine, just to make sure that we don't have some kind of a lingering damage, and obviously at that point assess if that elevation of the creatinine is related to the PPI versus to something else. And I also ask them to consider magnesium supplementation in some patients, because we do see that hypomagnesemia issue, and also monitor the calcium. So magnesium and calcium and the kidney function.
Any other questions for Dr. T?
Thank you very much again.
George, thank you so much.